Hi, everyone. I'm Dr. Pavana Pathak. I'm a hematologist and oncologist that specializes in breast cancer, and I'm also a certified yoga teacher.
So cool. So tell us a little bit about your background, like, where you went to school and how you got into this field.
Yeah. So my parents are originally from Nepal, and my father was an orphan, and he was adopted by a man who eventually developed head and neck cancer. But that man, raised my father, and ultimately my father was able to sort of excel and come to this country under what was then known as the Fulbright Scholars Program. Mm-hmm. And actually from that, there's another round of scholarship called the East-West Centers Program.
Okay.
Which is located in Honolulu, Hawaii. And so that's where I grew up, in Hawaii.
Oh, that's nice.
And fun fact, that's actually where our former President Barack Obama's father, that same program, the East-West Center Scholars Program, where he immigrated from Kenya. So, I grew up there, and I have an older brother. He's about 10 years older than me. Mm-hmm. And he's also he's an MD, PhD, also in the field of oncology. He works more in just sort of approving diagnostic devices and molecular studies for patients. But both of us were inspired by my father's story. And so every day we would come home from school and pick up a flower and sort of put it at the altar of the picture of the adoptive uncle. Right. We'll call him Mamaji. And it was sort of one of those stories of an immigrant family coming here trying to assimilate. My mother was 15 when she was married. Back in South Asia, certain parts, especially, not all parts, but certain parts, it's very regressive. And so she didn't really have an opportunity to get educated. And she opened a daycare center. And I'm sharing this with you because I feel like that's a lot of how I think of patients and life in the sense of just nurturing and cultivating people. I grew up there doing that every day, helping her in her daycare. Right. And just seeing her and my father just sacrifice so much, it kind of drove me and my brother to pursue a very academic career. Right. So for him, he went to Harvard at age 15.
Oh my gosh.
And then pursue those degrees. I said, I think there was one other one, an MPH. It's okay, put another feather on there, But then, and then myself, I got into med school from high school in a 7-year med program. And so I went to Boston University. Right. And, going from Hawaii to, we made a pit stop in Washington, D.C., moved during the midst of my high school, which was hard. Yeah. And then went to Boston. At Boston, I studied anthropology as a sort of a co-minor, as part of my medical sciences kind of track from college to med school. And that was inspired by growing up in Hawaii and seeing sort of the diversity of thought, diversity of cultures, food. And again, that also inspires a lot of how I view patients and systems of healing, because I feel like everybody has a different perspective, and often they're very valid in their own right. And so that's what sort of led me to really enjoy the melding of fields. And so then within med school, I really just enjoyed everything. I was should I be a surgeon? Should I be an internist? Should I be a pediatrician? It was everything seemed very hopeful and exciting to me. But what resonated with me the most was the field of internal medicine, where I get to sort of sit with patients, listen to them, come up with questions together. Right. And then throughout all of this my life, there's always been this connection to patients who are sort of at the edge of life. Inspired from the very beginning with my father's story and his uncle, and even in my school age years, volunteering at respite homes for terminally ill children, to during my residency, I ended up doing my residency at Johns Hopkins, and the cancer center there, the Weinberg Cancer Center, just felt like a I mean, Hopkins itself felt like a temple of medicine.
Right.
But the meaning that it felt like there was a reverence for patients and a reverence for the process of healing. And but within that, the cancer center was just so special. Like, it was just a place where everybody was on the same team.
Mm-hmm.
Like, it felt like you were going to like a football practice in a way, where you're
right.
like, you know, the nurses, the pharmacists, and like the students, the, you know, palliative care doctors, the surgeons, the oncologists. We were almost, you know, in some ways we're an afterthought. We're just part of the process.
Right.
That really inspired me to be like, hey, this is probably the direction I'm going to go in. But I did spend a year there as an internist, kind of just honing my interest in like general medicine. And then I finally decided to pursue my fellowship in hematology oncology.
Right.
And within that, I basically, and prior to that, during my residency, I basically fell in love with the idea of physician wellness, physician well-being. Mm-hmm. And, you know, that story also has threads from years prior, but right. specifically seeing physicians in my life, seeing people in my life, caretakers struggle and suffer. And this is now a decade ago. It's 2013. We helped create one of the first physician wellness programs formalized physician wellness programs for physician trainees then. And we sort of disseminated it. And then that sort of translated when I went to fellowship. I felt like oncologists specifically are very under a lot of stress. And you know, I'm talking from an oncologist perspective, but like patients, of course, themselves are under tremendous stress. So it cannot be healthy for the patients to be receiving care from people that are unhealthy.
Sure.
So I really dove into just how to cultivate resilience within oncologists, the patients, et cetera. And I myself faltered. I struggled during that time. And, you know, we can unpack all that, but essentially in that I discovered several tools to help me, to help my colleagues. Mm-hmm. And then now I'm in practice now for the last 5 years. And I've just, I really feel like I've found a home where I can hear, where I can share my, you know, the things I've learned medically from, you know, from an oncologic perspective.
Right.
But really, I think the biggest thing I share with patients from a day-to-day basis is a lot of the other tools I've learned along the way, which include yoga training.
Right. Right. So there's so many things that you said in there that like I kept in my mind, like all these questions kept, you know. Well, one thing I noticed right away was when you said that you and your brother both like pursued academics. Mm-hmm. I thought it was interesting because when you think of academics, you think of like being behind a book and teach, but really the academic route you both chose was really helping people. So I thought that was an interesting kind of little side note there. You focus a lot on integrative oncology, and I thought it was interesting that also that encompasses in some way the physician side of things, which is something that you don't always think about.
Yeah.
But I want to talk a little bit about integrative oncology, like what that entails exactly.
Yeah. So integrative oncology is the idea that you have conventional therapies such as your chemo, your surgery, your radiation. Right. And then you have an additional realm of therapies that are what we consider holistic. We've used different terms in the past like alternative, complementary, etc. But really, again, going back to the idea of like, you know, different healing systems have different values and they're all valuable in their own right. So being able to take a look at the patient as a whole person, and I take a step further and taking a look at the whole health system, you know, from a step back, and that includes the caretakers taking care of the patients.
Yeah, that's interesting. And, you know, it's interesting because also on a lot of other episodes that we've done, we have touched on a sort of mind-body connection. Yeah. And, you know, where your mind is, you know, when you're suffering or, you know, dealing with something, it really affects how your body is going to respond.
Absolutely.
Right?
Absolutely. Definitely. And I think the science of yoga, which is the word yoga is from the word, is a a Sanskrit word coming from the word yuj, which is a union, or uniting the mind and the body is one of the simplest ways to look at it.
Yeah.
And the reason that's important is because, there's this concept that the body keeps the score.
Okay.
And so things that we consciously do, we can perceive, like if you break your arm, you've broken your arm.
Right.
But oftentimes there are traumas, micro traumas, and may not feel like something traumatic, like you didn't have an earthquake happen or you didn't, go through a divorce, but it might be something else. Sometimes it may just be like a cancer diagnosis or hearing the news that you have a lump in your breast from a radiologist, right? Those types of encounters and experiences get stored in your body. And for better or worse, it's upon us to work through that.
Yeah.
And yoga is just one avenue. I think there's a whole menu of things you can do, but it's certainly a science.
Right.
And it's not just the postures, actually.
Right. That's what I was going to ask you next.
Yeah.
Like, what is it about yoga? Because, you do the postures, you do the stretching.
Yeah.
Child's pose is my personal favorite.
And so, part of why I wanted to embark on training in yoga was, one, to acknowledge my ancestors and this sort of incredible wealth of knowledge they unearthed at some point, 5,000 years ago.
Yeah.
But that's still applicable today, But also, it's essentially a way, it's a vehicle to get in touch with yourself and have what they call communion with sort of the universe, which and many people can get afraid of yoga. They feel like, okay, it's like this foreign language. Maybe it's the occult. Maybe it's religious. And, I'm here to dispel all of that. Right. It's essentially just a method it's like a scientific method. It's a way to ask yourself questions. And I can summarize a lot of what it is technically. So there are different figures who kind of expounded upon these things, wrote about it. There's a figure named Patanjali, and he wrote this 8-fold path of yoga. And the first 2 paths don't have anything to do with postures. And if it's okay, I'm going to share the Sanskrit name because I think it's important to, especially as we delve into the Western world, not appropriate things, but appropriately acknowledge things, so we can learn from it, we can modify it. So the first 2 things are the yamas and the niyamas, and those are just basically kind of codes of conduct, suggestions for how to live, which I think anybody could agree with, like don't steal, be kind, don't harm people, use your energy wisely, these types of things. Sure. Those are the first few. Cleanliness. It's like common sense stuff your mom would whack you on the head to do, right? So that's, everybody can agree. Then the third phase is what we call asanas, which are the postures. Okay. And, originally there were only maybe 16 or so of them. And then we've now evolved into this sort of modern day era where we have goat yoga and wine yoga. And sure, all of it in some way, it's all about cultivating awareness. Yeah. So, I don't judge it, even though, coming from a more traditional background, I think it's all helpful and important. So that's only the postures we do on the weekends, the hot yoga flow, which I also do a lot. It's a part of it, but that's a step to the theoretical next suggested step, which is called pranayama or breath work. Pran means your life force. Yeah. And pranayama is the control of your breath. So now the latest fad on TikTok is now breath work. Right. And so
I'm not aware of that.
Yeah. So I don't know, these fads has been around for a long time, but so it is, because your breath is the connection between your mind and your body. Right.
Which they do sort of talk a lot about during a yoga class.
Exactly.
I do take some yoga.
And I heard this really funny quote. I don't know if it'll offend anybody, but it says yoga without breath is bad calisthenics. Oh. So it's just, it's this idea that your breath is what connects your mind to your body. And medically speaking, it connects your parasympathetic nervous system when you take a big inhale, expand your diaphragm, and when you exhale, to your sympathetic nervous system. And the system, the parasympathetic is what controls rest and digest, your ability to relax. And the sympathetic is your fight and flight. And that is the most critical interface between the two. It's the only thing you have voluntary control over is your breath, and also involuntary. Yeah. So anyway,
That's
so
interesting.
it's very important to use the breath, and then moving into, more formalized breath work with pranayama. Then there's the next phase. There are 8 steps, and then the next phase is dharana, or sort of withdrawal of the senses. And so that's the idea of sort of kind of centering yourself more.
Right.
The phase beyond that is called dhyana, or meditation. And so a lot of the ancient sages said a lot of the point of doing yoga is to get into a meditative state.
Right.
And that meditation, ultimately, which is cultivation of awareness, you don't have to sit in a boring room and count sheep or like whatever you think it is. There are thousands of types of meditation.
Yeah.
The point is to cultivate awareness. And then from there, the last phase, and I say phase because it's constantly an evolution. There's no ultimate peak you can achieve within yoga. But the last phase is what we call samadhi, or connecting to the universe.
Okay.
And when you do that in different ways, like when you go out to walk in nature, when you hug your child, you feel this like ebullient sense of bliss. And that's why we get to varying stages of that samadhi, like every day, but also specifically when you do these practices.
Right. That's so interesting. I love how you just broke all that down. Because I do take some yoga, and I do that. I breathe when they tell me to breathe.
Yeah.
And, but to hear it all broken down is really interesting. And I did mention this to you before, but my father had lymphoma for over 30 years. And initially he was told that he would live 10 years. And he started doing yoga, which was so like weird for him to be doing. He was so not a yoga type of person.
Or who he was.
Yeah. And I want to say this was in the 80s, even like the early 90s. And he swore by it. He did it religiously. And he always said that it was the yoga that prolonged his life.
Yeah.
Actually. So
he said that.
Yeah.
How did it make you feel as a daughter?
It got me doing yoga. I would go with him to yoga.
Yeah.
So, it was definitely, and I, honestly, I actually feel like I connect with him when I do yoga. That's really sort of what.
That's so sweet.
Yeah.
That is very, very, and it's probably true. There's there's that parts of your body, like I said, the body's keeping the score, that remembers those moments.
Yeah.
And your dad wasn't wrong. Now, right, in the 21st century, we're discovering that it's true. We have studies showing that patients with cancer who do yoga, as compared to like a placebo program, just a generic health program, do indeed have lower inflammatory markers. And acute and chronic inflammation, we know, are like poor harbingers for cancer prognosis, meaning we know reducing your inflammation with a cancer diagnosis is critical. And so the fact that he was doing it, he was like, decades ahead of his time. Yeah.
So interesting. Yeah.
Yeah.
Well, so turning now to women's health, because that's what we're going to talk about. So one of the things that we were talking about with the, yoga and the meditating and the breathing, I was surprised to read that cardiac or heart attack is a number 1 killer of women. Because you sort of think of men more associated with that. And I guess men have more heart attacks, but more women die of heart attacks.
Yeah.
So I would think that something like, yoga or like, a way to relieve stress would be beneficial to women.
Could yoga be useful for women who are at risk for cardiovascular disease? I certainly think so, in the sense that becoming more mindful of your body is one of the first steps you can take to making choices for yourself, whether that's healthy food, healthy activities, but also recognizing if you're having the symptoms of cardiac disease. It's not just the weight on your chest, left chest pain that we think of. In women, not most often, but it can often, more than men, present as more subtle symptoms such as nausea, or neck pain and shoulder pain, and things that are recurrent, persistent, and worsening is what I'm talking about. But it is certainly something that the more women that are aware, the more women that will get help, and get help at a time in which things can be done to give them back a quality of life or save their life. Right.
Yeah, I think that's something like, because I think a lot of women's health issues, the symptoms are subtle, or I feel like also women are so adept or used to kind of brushing things off. Like it's very normal for a woman to have a weird pain here or an ache there, and you just kind of like brush it off without really thinking it could be anything.
Right. Women are usually the first ones to mobilize to help someone else.
Yeah.
And especially February is
Heart Month.
And I think specifically for women too.
Yeah.
We wear red. Some of my best friends are cardiologists, and it's like something that's very dear to them.
Yeah.
So yeah, it's very important to raise awareness, and then also know the tools we have to cultivate awareness.
Yeah.
And then also beyond that, speaking of physicians, one of my dear friends, Dr. Laurel Brown, she was sort of my mentor in residency. She's a cardiologist, and she's actually won an Emmy Award, like a local Emmy Award, for creating a CPR video to train people about the importance of not only recognizing it within yourself, but think of it. We just said women are the first to mobilize, but mobilizing when other people have this. So it's an important issue all around, not just for the individual, but also as a society.
Right. And I think on the individual, side of it, I think just being aware of your body and like knowing when something's not right.
Yeah.
Right.
Yeah.
So, all right. So let's talk a little bit more about women's health in general. So what are some things women can do to live healthy lives?
Yeah. Well, some of the things women can do to lead a healthy life, I think, start first with the idea of taking care of themselves and self-care. It's like they say when you go on an airplane, put your own oxygen mask first before you put it on others.
Yeah.
This is a lesson I'm still trying to imbibe and learn myself as a mother. And so with that principle in mind, a lot of things fall into place, whether it's talking about the specifics of screening and things, which I can rattle off to you, which I'm happy to do.
Yeah, we'll get to that.
But I think one of the best things a woman can do, is to cultivate some kind of mindfulness practice. And that is because mindfulness is the idea of cultivating awareness, but cultivating awareness about what is within you, okay? Because I think women have a very huge, tremendous power. In the Indian tradition, we call it Shakti. That is the sort of divine feminine form.
Okay.
And we have this huge intuition. And we need to tap into that more. It can guide us to answers that we don't know in the current state. And in order to do that, you need to be aware and not be bogged down by the stresses of life, caffeine, this or that, And that's why these practices, whether it's yoga or meditation or Tai Chi or art or music, things that are not so on the beaten path of what society tells us we need to do from 9 to 5. So carving out that time, whether it's 5 minutes, 2 minutes.
Right.
You're a mom as well, right? So you know how hard it is, and to find even 2 minutes of time. But even if it's in the bathroom while the kids, locked bathroom, while the kids are knocking, saying, "Mom," just to take a step back to do that first. And then I think certainly from a clinical perspective, we know that regular exercise is like the best medicine. Yeah, it's an antidepressant. It's a cardiac medicine. It's your aspirin. It's your so many other drugs in one.
Right.
And it's because, again, the magic of the body doing all of its metabolic effects. And it's not just limited to just losing weight, but just the act of exercising 30 minutes a day. And if it's not 30, break it down into 5, 10. Learning about what types of exercise can be helpful. I believe yoga is a comprehensive exercise. You can get strength training, cardio, flexibility, all of that in one. It was designed in that way. However, educating ourselves on what different exercises can offer. So like resistance training and weights, like how does that change your body? And the reason I share this with you, Stephanie, is because my mother, as I shared, did not have a chance to be educated. She was to the degree, that I was, right? She gave me that opportunity. But since seeing her health journey, she was like a beautiful young woman and then came to this country. And specifically in this country, we see a lot of people's health, especially when people immigrate, turn south. Higher rates of autoimmune disease, higher rates of cancer.
Oh.
And she developed, through the course of, 20, 30 years of being here, diabetes. And seeing how that diabetes affected her, and with her level of health literacy and understanding, and, she did her best. She gave us the best food that she knew, right?
Right.
But then seeing her transformation, even as somebody who didn't have those opportunities, to take it upon herself to learn. Mm-hmm. And so she learned that, physical therapy and weight training can be good for her diabetes. Oh. And so it's the cutest thing to hear her say, like, oh, I just did my weight training. And like, it's the cutest thing to hear her talk about her, like, mindfulness practice or whatever it is. Yeah. And so, and just saying that, take the opportunity to learn also about your body.
Right.
In so many parts of the world, periods are a shame. People put into houses and put there for days, and it's easy for us to judge because we're like, oh, how would you do that to a woman?
Right.
But when you come from the perspective of, like, they had their own way of doing things for years and hundreds of years and thousands of years, and then but when you take that individual who may now be here, or if it's not in Nepal, like where I'm from, but it could be Kansas,
right?
Somebody may have had a certain type of upbringing that gave them certain health, and so we almost inherit. And maybe you can understand, like, we almost inherit just as much as we inherit genetic material, predispositions to cancers or whatever. We also inherit a living sort of inheritance of our health, and health knowledge, that we can change.
That's a really good point, actually. That's a really good point. Like when we, talk about risk factors. Yes, that's a really, really good point. Like we talk about risk factors and modifiable and non-modifiable. Your attitude should be listed as a modifiable risk factor.
Totally.
That's really, really interesting. I'm going to remember that. So as we were saying, breast cancer is a very, common issue for women.
Yeah. 1 in 8.
1 in 8.
Yeah.
So let's talk a little bit about breast cancer.
Yeah.
And why is it so predominant? I mean, why 1 in 8?
That's a good question, Stephanie. And if I had the answer, I would be very rich. But I think there are some certain known factors that lead to breast cancer. And then there are some modifiable risk factors. Okay. And so it's sort of a spectrum. And so some of the things we can't change, going from one end non-modifiable to the modifiable, include being a woman, being female. We can't change that usually, and we are more predisposed to developing. Your age,
right?
Okay? As you get older, you're at higher risk for developing breast cancer. And the way I explain it to my patients is that, our bodies, when we're younger, we have this really beautiful immune system that's sort of like the surveillance cops going around getting rid of cancer cells, bad guys, etc.
Yeah.
And just like your bones, just like your kidneys and your heart, everything gets kind of weaker over time, and we're less able to patrol these cancer cells that emerge. Right. So that's another reason why, age. But it's also one of the rationales behind screening, which, I know we'll get to, but specific, age points at which we might want to do that. Okay. Where the benefit of screening becomes way more than the risks of screening.
Right.
Okay. Then other risk factors kind of emerge from non-modifiable to modifiable. So things such as your genetic history, so your family, right? Did you have a mother with breast cancer? Did you have a grandmother? Did you have a cousin? Yeah. But I think the biggest fallacy I hear from people is like, I knew nobody with breast cancer in my family. Yeah. But remember, maybe your lifestyle changed. Maybe you came to this country. Maybe, there are a lot of different reasons why it's emerging more nowadays. Yeah. And we can tap on that as well. But some of it could be the chemical exposures we have. Some of it could be the stress. Some of it could be the type of sleep we were getting. Certainly diet, lack of exercise, all those things. Yeah. But then, again, like the other choices we make. So birth control use can lead to a higher risk of breast cancer after a certain amount of years. Yeah. Hormone replacement use, specifically after at least, 5 years, can lead to increased risk for breast cancer. having children early or having children late can also, or having no children at all, can lead to higher risk for breast cancer. These are all choices we make, darn you women making these choices.
I know.
This part of our, just something that can happen to us,
right?
Regardless of the choices we make in life. But essentially having a longer period of literally having periods, like an early menarche, having your period early, and then having a late menopause, that window of time, having a longer length of that can increase your risk for breast cancer.
Because the more hormones.
Yeah, exactly. And then having no kids or having many, many, many kids can be a risk factor. And then turning into sort of the more modifiable things like, okay, did you ever have a history of chest radiation?
Right.
Well, that can potentially thoracic radiation. Sometimes people have like a lymphoma in their history, and then,
right.
Now, does the benefit outweigh the risk at that time? Certainly. And we have ways to prevent breast cancer. So I'm not saying, don't get the radiation, but it's just something to know and be aware of.
Right.
And then other things. I think the biggest modifiable risk factor, hands down, is obesity.
Okay.
So obesity is a huge factor in the recurrence risk and incidence of breast cancer, and across a lot of other cancer types.
Yeah.
We now know that fat tissue, or what we medically call adipose tissue, is active. It is not just like a passive, pudgy standbyer, okay?
Right.
It's just active tissue. It sends inflammatory signals, and it does a whole bunch of things in your body, especially visceral fat, which is surrounded around the abdomen, that can unfortunately lead to increased incidence of cancer. So that is one of the reasons why, as a society and, with my patients, we really hone in on exercise, especially before, during, and after a cancer diagnosis. And even now, there was a study out of the San Antonio Breast Cancer Symposium. It's like our premier breast cancer conference annually, that said that women with metastatic breast cancer, meaning stage 4, it is sort of not in the curative setting, even metastatic breast cancer can benefit from exercise.
Oh, wow.
And so we know that obesity is a problem, but like exercise can be a really low resource, like available solution to that.
Yeah. So interesting.
Yeah.
And there's also smoking.
Yes, smoking. Let's not forget. Yes.
Right. That's sort of one of those for every kind of cancer too.
Definitely true. Yeah, definitely true.
Interesting. So let's talk about screenings.
Yeah.
So when does a woman want to start screening for breast cancer?
So this is a hot debate topic. And to kind of set the tone, in our society, we have various different societies. American Cancer Society, the USPSDF.
Yeah.
These are the United States Preventive Task Force. And American Cancer Society, there's all the different types of societies that have put out guidelines. And it used to be that women, 55 and above, or 55 to 70 should get screening. However, recently, that age has been brought down.
Yeah. From,
in your 50s to now 45, and actually 40.
Yeah, 40.
Yeah, so 40, and so sometimes it's hard to give a discrete number because in reality, it should be a conversation between the patient and the doctor. At 40, they say you should consider having a mammogram annually. Okay. And I would say that if you have a family history of someone having breast cancer, especially early, you should probably start having breast screenings at least 10 years before that.
Sure.
And then I'd also add to that, if you have a genetic susceptibility, meaning you've been tested and you have a gene,
right,
like a BRCA gene or whatnot, you may need to start testing even sooner than that in your 20s with different types of tests, such as MRIs and things like that.
Yeah.
So I would suggest 40 annually,
right?
45 for sure.
Yeah.
And then I strongly feel that we should continue screening as long as a woman has a good quality of life.
Right.
I think there's a little bit of ageism and at times saying that, we should stop at a certain number, but age is just a number.
100%.
Age is just a number. I have 7-year-olds who can do more push-ups. I've seen 7-year-olds who can do more push-ups than me, and it's not relevant as much anymore, but their functional status, what we call functional status, how able they are to get along in their life is a far better predictor.
Right.
Yeah.
Right. Yeah, I agree with that. I was going to say, what about some people say that at 35, women should have a baseline mammogram?
35, I think, I'm not sure the data has brought that to total fruition yet, because when these societies, calculate their number, they take a look at how many mammograms you need to do to kind of like save one woman's life, know? And I don't know what the data is behind 35, but I do know that there's certain populations, such as women with dense breasts, that would benefit even from, a screening ultrasound perhaps earlier than 40.
Okay. Yeah, let's talk about breast density. So what exactly does that mean?
Breast density. So breast density refers to the fact that in our breast, we have a couple different types of tissues, but there are glandular tissues, the tissues that produce the breast milk and those substances. And then there's fat tissue.
Yeah, right.
And then there's, of course, the connective tissue that, links all of it. And then there's skin. Breast density refers to the fact that there's probably a higher preponderance of this glandular tissue, and it's essentially fogs our ability to detect breast cancer and certain types of breast disease,
in a mammogram.
In a mammogram, in more conventional methods,
right?
And so for that reason, these women are unfortunately at higher risk for developing breast cancer, and whether that's a factor of the breast density itself and or the screening technology that's and or the societal policies on when to screen, etc.
Yeah,
I think we still have to learn more about.
Yeah. So what options are there for women with dense breasts?
So there are 3D mammograms, and I know a lot of the radiologists and physicians here at RadNet can speak more to that. But this is a specific technology that allows us to see the breast tissue rather than, in a kind of a one-dimensional plane on an X-ray film in a much more dynamic light.
Yeah.
And so that has increased the sensitivity of detecting these smaller tumors amidst dense breasts.
Right. Okay, so what about let's shift now to older women, like post-menopause. What are some things they can do to be healthier?
Yes. So I think, again, the first and foremost thing is probably exercise, because after menopause, women tend to gain some weight, and it can be hard, as we know. Like, getting rid of the menopause belly is something we always hear from some of our older patients. And so exercise is I think, one of the biggest things. Also recognizing when it's that you are still, at risk for breast cancer. I've had a number of patients tell me, I went through menopause. How can I be making estrogen anymore?
Right.
Well, the dirty truth is that there's estrogen that's produced from your adipose tissue. The adipose or fat tissue produces estrogen.
Oh.
Yeah. And so do your adrenal glands, et cetera. So the more fat you have on your body, the higher risk you are, unfortunately, for developing breast cancer. And so it's this like little loop. It's not good.
Right. Right. Interesting.
Yeah.
Huh. Okay. So what about, let's step outside cancer for a second
and
talk about, let's put that away for a minute. Let's talk about some other screening that women should be, sort of militant about getting for their health.
Yeah. So I'd say from head to toe, in certain populations, like a Caucasian population or anyone with a family history of melanoma or skin cancers, seeing a dermatologist for complete skin exam.
Yeah.
Otherwise, what we know, especially screening tools are important if they can make a difference in your life, right? So you don't just screen for like the rarest of tumors, because we know it's so rare.
Yeah.
So we're talking about the cancers that occur most commonly. So we're talking about, when you talk about disease and death, we saw cardiac disease, and then cancers fall next as something that can be prevented. And so colorectal cancer is another huge thing.
Yeah.
And you made a comment earlier about how, the incidence is increasing and increasing in younger people. Yeah. And that is definitely true. We don't know quite what it is. And it's not just that we're just detecting it more.
Right.
So colorectal cancer is, just like breast cancer, it's important to detect early because the earlier you detect it, the likelihood of cure just is exponential.
Right.
Okay.
Right.
Stage 1, stage 2, you're looking at life expectancies that feel normal, just as in breast cancer.
Right. And they did drop that age also down to 45.
So correct. So that was what I was going to say is that just like breast cancer screening, 45 is the new number for getting your screening colonoscopy. And so I know that might be scary for some women, but I've had 2 in my life already. And so it's just one of those things. And I share that because I think it's important to have some transparency to know that like your health professionals are just humans and we're all in the same boat trying. Right. So getting your colonoscopy is another step you can take. And if you're afraid of doing that, although that's technically the gold standard, there are other modalities you can use. You can ask your doctor about. There are now stool tests that look for cancer DNA. If it does test positive, you may need to do a colonoscopy anyway, but that's important.
Yeah, absolutely. Yeah, and I guess there's also, blood pressure and, that.
Yes.
So we talked about,
so blood pressure as well. I think I had a patient today, a woman who was in her 50s, and she was reporting to me a lot of different complaints that were not necessarily related to her cancer. And I asked her, I was like, do you have a primary care doctor? And she's like, I think I do. Oh. And so I was like, okay, that at 50, just like at 35 or 40, when certain, they say, fertility can drop, these things. At 50, there's a certain kind of cliff where, not to say over the hill or anything like that, but it's just certain aging processes start to take over, and so we really need to make sure you're getting in and have an established primary care doctor.
Right.
In terms of what can you do? Have a primary care doctor, check your blood pressures. You may find out like a hemoglobin A1C is a test that can look to see what is your it can be a test to see your risk for diabetes, but essentially your glucose control over the course of 3 months. So they may test for that, see if you're at risk for that. A number of other things. But another thing that is commonly done in primary care practices or gynecologic practices is a pap smear.
Right.
And so and that is done. The pap smear is named after a man, Papa Nicolau, the doctor or scientist that created the test. It's short for, pap smear.
Lucky him.
Right. And so that recommendation has also evolved over time, but generally anyone 21 and above every 3 years, especially if you've been sexually active. Yeah. You don't need to get before 21, but roughly every 3 years. Yeah. In your 30s, that cadence and even the type of test, you may not necessarily need a PAP per se, but that can potentially change. Right. And then the age limit on that can extend again. There's a kind of a discussion that can occur, but a cap I've heard is like 65. Okay. But again, those caps and these guidelines are very fluid. If you have a history of immunosuppression, HIV, family history of cervical cancer, personal history of cervical cancer, and also exposure to a drug called DES. Well, back, a couple decades ago, there was a medicine given to moms. With morning sickness that unfortunately led to an increased risk of cervical cancers and gynecologic cancers.
Some of those tests look for HPV also, right?
Yes, yes. So HPV is the other thing women can do. Well, it's maybe something the younger women, our daughters, right? Yeah. So our daughters, there is a vaccine against the HPV virus, which does not only causes cervical cancer, but can cause other cancers, head and neck cancer. Yeah. And so kind of killing 2 birds with 1 stone. But the vaccination, that type of prevention currently is limited to more of the pediatric teenage population.
Right. So hopefully our kids won't have to worry about it. I read this interesting article that talked about that societal factors affect women's health. Yeah. And, meaning that, like things like depression, like women are more susceptible to depression and, things like that. What do you want to say about it?
Yeah. Well, thank you for asking. Yeah. I mean,
we're sort of
as a breast oncologist and a yoga teacher, I see it firsthand.
Yeah.
The impact that certain decisions and policies have on women.
Yeah.
One thing that I didn't mention in sort of the ramp up scheme of modifiable and unmodifiable risk factors for breast cancer is the breastfeeding, for instance, is something that can reduce your risk of breast cancer. And when you take a look at the percentage of women in the United States that are able to breastfeed, it's very small.
Interesting.
It's unfortunately very, I think, I don't want to, it's something like 20% up to like, or less potentially up to 6 months.
Wow.
I think it's much less than that. And it's not the woman's fault. It's not the mother's fault. And it's not that you have to breastfeed or chest feed, however, but it is the fact that women often don't have, even despite employee policies that you should have a space to do this, don't have either the voice, the opportunity, the means to do so.
Right.
And that's a direct link in my mind to the incidence, right? To their health.
Yeah.
And more beyond that, paid family leave. We're like the only developed country, as rich as we are, that doesn't have paid family leave.
Yeah.
You know, and people in Europe are afraid sometimes. You read articles like in the New York Wall Street Journal and these types of talking about how it can be a dangerous place to raise kids in this country because our life is not set up for women. I feel working a 9-to-5 job or 8-to-5 or 7-to-5 and coming home and resuming domestic responsibilities. We need, like other developed countries like France or Canada, have a system in place for caretaking. And like my mother is a daycare provider, like have a far more robust system so that women can be at work, can have their biology not be a detriment, and then continue to take part in the unique things we need to do throughout our lifespan, to take care of our health.
Right. And also on that note, one other thing I want to add is regarding another article that I read that talks about how women's health has sort of been overlooked in the sense that, like, clinically and research-wise, you know, most research is sort of geared toward men and not women. You know, women aren't really used as much in research. And so...
So as an oncologist, I have that conversation with my patients when we talk about what to do after a breast cancer diagnosis. Right. And they say, Doc, you know, am I going to get a CAT scan? What tests am I going to do after? And I'm like, actually, you know, so certain other cancers like prostate cancer, lung cancer, pancreatic cancer, colorectal cancer, we do have guidelines on, you know, we do need a CAT scan every 6 months for 2 years and 3 years, et cetera. But for breast cancer, that's not the case. We say that none of those are necessary. Yeah. And certainly that recommendation has been based on certain studies that said, oh, you know, getting these CAT scans and things are unnecessary. But in my mind, I'm wondering what's more. Like what else can we do? Because how I monitor my patients after a diagnosis is our standards are to meet with a person every 3 to 6 months and just take a history. Just tell me, do you feel differently? Yeah. And we don't even have standard guidelines around blood testing. Yeah. For, you know, whereas other cancers like prostate cancers, there's PSA, colorectal cancer, there's CEA. We have very ambiguous, nebulous cancer markers for breast cancer. So that in my mind feels like that's insufficient. Yeah. Fortunately, there are new technologies and companies that are emerging. Just last year, we had a new technology called circulating tumor DNA that was approved for the use in breast cancer. That is a blood test that we can use to monitor women after a diagnosis to detect breast cancer at its earliest stages when it's just shedding DNA into the blood. Wow. Not even visible on an imaging test. Wow. So what that tells me is just that we need to make this type of technology more visible, more accessible. Yeah. Not all insurances pay for it, even though CMS, the Center for Medicaid Services, approved it last year. So there needs to be more of awareness. Yeah. Yeah. And so that we can capitalize on the existing technology and then advance to the next level. Right. Yeah. Well, hopefully there will be more of that and more women like you and physicians like you who sort of have awareness of the big picture, which I think is really cool. Yeah, well, thank you so much for asking me all these questions. This has been a great conversation. It has. Thank you so much. Thank you, Stephanie.